Okay, let's do a quick review of some of the respiratory problems in chapter 27. So first up is asthma. And this is just a picture to kind of review some of the pathophysiology. This is thought to be like an allergen-antigen mediated response. And because of that, it creates a hypersensitive reaction that results in decreased airflow due to inflammation, bronchoconstriction of the airway. That restriction can be caused from edema, mucus production, and there are different types of asthma. There can be exercise-induced asthma. We see it infantile in children. And sometimes we see it manifest in just older adults. This is known as a chronic disease, but they will have acute exacerbations that they're trying to control. Some of the increased risk factors that we see are when they're in situations where they have exposure to certain allergens. And so a lot of times when patients have asthma attacks, we'll try to ask them, was there anything that brought this on? So, maybe it was some type of dust, or maybe it's seasonal due to things in the air. If possible, then if they can identify some of these triggers, then we may try to ask them to control exposure to those triggers. Exposure to smoking, obesity. So those are just some of the triggers that we will see. And again, this is another picture that's just showing kind of like the inside of that bronchiole, and then once there's edema and inflammation, how much that can constrict the airway. So it should typically be open, but with asthma, we're seeing that we have that bronchoconstriction due to the edema, inflammation, and increased secretions. So how are we going to assess for this? What's some of our important cues that we'll see? History sometimes so subjective data that they can provide. You want to look at vital signs and that O2 saturation. Observe their respiratory effort. Are they having increased work of breathing? Any type of like nasal flaring or retractions. So retractions, they'll kind of pull in under the ribs or sternum area. When you listen to breath sounds, you might hear a wheeze, and sometimes this will be audible without even a stethoscope. So you'll hear wheeze, coarse breath sounds, and you'll see that prolonged expiration. They may have a decrease when you're during auscultation, decreased in breath sounds. This can be a very ominous sound because if they are decreased or absent, like maybe they've come in wheezing and then suddenly they're decreased, but they're in distress, this can actually be a sign of one of our complications that we'll talk to. They may have difficulty talking, so they speak in short, broken sentences. They may complain of, tightness in the chest, itching around the neck, fatigue, coughing at night. So look for that restlessness, tripod positioning and breathing, pursed lip breathing. Those are all things that you will see. And then this shows that if we have a patient with asthma and when we ask them about any incidence of these symptoms, they don't have any of these, it doesn't mean their asthma is cured. It just simply means we have it controlled effectively. So that's a good thing. And that's our goal, is to get our asthmatic patients to where they're controlled. If when we talk about these symptoms, they have 1 to 2 of these symptoms, then they're partially controlled. And if they have 3 to 4 of these symptoms, then that is considered uncontrolled. And so we need to be working at getting better control of asthma. So what's our priority interventions? So with just our patients in general, our priority is going to be to control and prevent those acute exacerbations. And so we're going to talk about some meds that we have that can help with that control. In the event they're in an acute asthmatic attack, then we are going to try to improve that airflow and gas exchange. If they are having an acute crisis and show up to the, emergency room, we're going to do, immediate responses with oxygen therapy, trying to open up those airways with bronchodilators. When they're stable enough, we will try to get a chest x-ray to see if there's any type of infiltrates or pneumonia that may be triggering this. We'll also, with these patients, if they're stable and maybe, not in the emergency room, but if we're trying to get an indication of how well is our patients doing, we may do, pulmonary function studies, maybe some things that we do with our patients. And then all of our patients are going to end up with an asthma action plan. And with this asthma action plan, it will talk about, how to use the different types of inhalers to try to avoid acute attacks. And then we'll talk here in a little bit about some of our drug therapies that we can do. So some of our priority interventions or action are going to be anything we can do to aid in breathing. So it may be tripod positioning, sitting with the head forward, oxygen therapy, identify and alleviate any triggers. These could be environmental, lifestyle, and then teaching about the medications. In an acute attack, they need to have IV access and be aware that in an acute attack, if we can't, achieve good bronchodilation, we need to be prepared that these patients may need emergency intubation. So let's talk about our different drugs that we can use. I'll show you a little bit. We'll go into the book and look. They have a great table that talks about the different types of medications, and use that table to fill out the notes, those pharmacology made easy notes that I provided you in class. But what I wanted to show this about, because I liked how it just was showing that the relievers, or we used to call these rescue inhalers, these are those short-acting bronchodilators that our patients may use to try to alleviate an asthma attack. Sometimes they'll use these if they know exercise triggers it. They may use this to prevent an attack, or if they start having an asthma attack, it's these reliever class that they will use. Then we have the controllers, those long-acting bronchodilators. Now, these they may take daily, but the big key is they need to know that these are not used to try to control an acute asthma attack. They just need to take these as prescribed for prevention, but they take longer to build up in this system to get that bronchodilation. So they need to know the difference, and they'll typically have a reliever or rescue inhaler prescribed, as well as controllers. And then you also get into that third category, which are our like anti-inflammatories or inhaled corticosteroids. We also have then some combinations that, again, these are not the combination ones, typically have one of the long-acting bronchodilators and one of the corticosteroids. So they're not used in a acute attack, but they need to take them daily because together they will try to provide that long-term effect to control asthma attacks from occurring in the first place. And so they've got that long-acting bronchodilator along with the anti-inflammatory. Now, one of our complications that we have is this status asthmaticus, and this is when they have an acute asthma attack. They can happen very quickly. It doesn't respond to their common, like short-acting bronchodilator, or sometimes we'll see this when they have not carried their short-acting bronchodilator with them. So in the event that they have an asthma attack, the first thing they want to do is use their short-acting bronchodilator as prescribed. And if that does not occur, they may need to seek emergency treatment because they may need IV fluids, systemic bronchodilators, emergency meds, like injectable steroids, epinephrine, oxygen. And again, once they hit those ER doors, we are going to put that IV in, provide that high flow oxygen, the meds as ordered, but in the back of our mind, we need to be prepared for emergency intubation if those interventions do not work. These patients can develop pneumothorax, cardiac, or respiratory arrest. And so sometimes with these, you'll see them come in, they have large audible wheezing, and then all of a sudden you'll hear kind of just silence. And it's actually because there's so much constriction that we're not getting any airflow at all with these clients. So that is one of the biggest complications would be we want to try to prevent status asthmaticus. And then we also want to try to prevent any long-term damage to our airways for these patients that maybe are in that uncontrolled asthma. So they're having lots of symptoms frequently. They need to be in communication with their provider. And these patients will also often have med changes a lot to try to get them controlled, because if they have frequent asthma attacks, they can end up having airway remodeling or damage to those airway structures. So that's something that we want to try to prevent. So some of our nursing implications are going to be teaching about the correct use of our inhalers. And so they'll have those meter dose inhalers, dry powder inhalers. They may, one of the most frequently with our inhalers is that sometimes patients don't know how to use them, and they'll inhale the medication to the mouth, but it's actually not getting down into the airways. And so sometimes they'll use spacers to help with that administrations. They may have nebulizers at home to help with that. So we need to do teaching about that. Review that education from pharmacology or fundamentals if you need to brush up on that. And then we can also talk to them about just some of that positioning, like abdominal breathing, pursed lip breathing, trying to help them identify any environmental or triggers that they can try to avoid, and that teaching about, status asthmaticus and seeking emergency treatment if their symptoms are not relieved by those short-acting bronchodilators, that they need to seek emergency care immediately. So with your education, again, teach about avoiding triggers, good teaching so that they understand what is a short-acting bronchodilator, what's a long-term, and correct use of those inhalers. Encourage good hydration so that they keep that moisture to the airways. It'll help liquefy secretions. And that's some of the best things that you can do with education for your asthmatic clients. I have work today on highlights, and in one of my announcements, I posted a link that you can subscribe to highlights, because we're not going to have time to go through all of these here, but this will just give you a peek to see some of the things that I highlighted. And then I want to go down to, this is gives you a good idea, and again, it's that same thing we saw in the PowerPoint of what are the asthma symptoms, and then how do we identify them as, do they have uncontrolled asthma or controlled asthma? So we already reviewed that. And I want to scroll down here. This is that stepped approach for asthma. So with our controlled asthma, they may just need that short-acting bronchodilator, and they may not need daily drugs. But if they continue having symptoms, then they go up to the next step. And so that's where they will add in like a low-dose inhaled corticosteroid or the leukotriene modifiers. If that controls their asthma, they'll stay right there. Sometimes they can go back to step 1. If they're not controlled with that, then they'll go up to step 3. So this shows you how important that follow-up care with that medical provider is, because they may need to go up steps or back steps. and switch around their inhalers. And so anytime they have med changes, again, it's very important that the nurse helps them understand what they should be taking. This was the table that I encourage you to look at when you're filling out your farm sheets, because it does a good job of showing, bronchodilators. You have the short-acting bronchodilators and the long-acting, and then it just really does a great job of simplifying these nursing interactions. So this is a great table for you to take a look at and review. And again, let me know if doing these highlights are helpful. I'll try to keep that up if it's something that I find that students are liking. Have a great day.